Now we're going to talk about induction of labor. Simply what induction of labor means is that there are methods or medications that are given to ripen the cervix to help progress labor. Some of those medications we're going to talk about here in a few minutes, but what are some indications and contraindications for labor induction? We do not want to induce a labor if there's fetal distress. That will cause more distress on the baby. We do not want to induce labor if mom has an active genital herpes infection. If it's an active infection and she was not getting treatment, it's active, she is going to have a C-section. We do not induce labor if it's a placenta previa. And all of this is coming from page 461, box 17-8. What are some indications? Why would we maybe need to do an induction of labor? Because mom's water hasn't broke, she's 41 weeks, she's not really progressing anywhere, she's only like 2 centimeters dilated. Well, indications that we need to maybe induce: she may be post-term, we may have a fetal compromise as far as when we're talking about IUGR or the isoimmunization, premature rupture of membranes with established fetal maturity. Mom may have hypertension, so we may want to go ahead and induce labor. So those are some indications and contraindications, and those are located on 461. What are some of the medications that can be given to ripen the cervix? Prostaglandin. It's prostaglandin E and prostaglandin E1 and 2, They ripen, and when I say ripen the cervix, what I mean is I'm softening and thinning it. That's what the medication is doing. So you're going to hear that term, you're going to see the term a lot, ripen. And that just means to soften and thin the cervix. The other things that can be done is giving the patient oxytocin. If they give oxytocin, and they can also do an amniotomy. These are pretty much the most common things that are done. And when we flip over to page 462, that actually gives you the medication box where it's talking about the prostaglandin E1, which is Cytotec. That's the one that you're going to see a lot or hear. Or prostaglandin E2, which is Cervidil. You guys can review that box. I'm not going to test you specifics on the prostaglandin E1 versus E2. Just be aware of their job is to ripen, soften, and thin the cervix. So they're there when you guys do your mother-baby rotation, and you probably will have a patient. You may have a patient who has had that done, and if you need to look up a medication, you can refer back to your textbook. But the other thing that I really want to talk to you about, because it's very important and it's going to be on boards and you'll probably see it on the test, is Bishop's score. It's on page 462, table 17-3. Now, you can see the Bishop's score, and it has 5 different factors that's given a score. We're looking at dilation, effacement, station, cervical consistency, and cervical position. Based on that score is given. They use that particular score because they want to know the ripeness. The cervical ripeness is the most important predictor of a successful induction. So the Bishop score is used because if you have, for example, a score of 8 or more, that means your cervix is soft, it's got 50% or more effaced, and it's dilated 2 centimeters. And also the presenting part is engaged. So more likely, that means your induction is going to be pretty successful. So the Bishop score is something that is used in order to assess the actual ripeness of the cervix and to see if the medications will be effective in doing their job. The other things that can be used in order to actually ripen the cervix is balloon catheters, which is essentially a Foley catheter, is inserted through the intracervical canal to ripen and dilate the cervix. What they do is they take the little catheter balloon, blow it up, and it's above the internal cervical os or opening with about 30 to 50 cc's of sterile water. That pressure and stretching actually releases endogenous prostaglandin. Our body has that naturally, so we're trying to help things along naturally. Seems kind of weird considering that you're putting in a Foley catheter, but there's just different methods. So this releases the prostaglandin naturally, and then usually what happens is the actual balloon will fall out once the cervix is about 3 centimeters dilated. This usually occurs about 8 to 12 hours after that's actually been inserted. I can't tell you that I know that they use the Foley balloon method very often, if at all anymore. It's mostly giving the Cytotec and Cervidil that they will use. Now we're going to talk about an amniotomy. Amniotomy is where they actually are artificially rupturing the membranes. So you may see it written as an AROM. So this means they did not rupture on their own. They actually took something called an amniotic hook, which I don't know if any of you guys crochet or have ever seen a crochet needle, but that's really about what it looks like. A long crochet needle with a little hook on the end that they go up there and they break the water. That's the other term you'll hear people say, they broke my water. So with the AROM, they do this because we want to augment labor. Labor usually begins within 12 hours after it's actually ruptured. So as far as the actual rupturing the membranes, it's painless for mom and fetus. She may experience some discomfort when they put this hook in. It doesn't feel pleasant. It's inserted into the vagina and the cervix. The presenting part should be engaged. The woman should also be free of any active infection of the genital tract. She should be HIV negative, or she should have a low viral load. That means that once they've looked at her viral load, it's low enough, and they say to her that it is an option that you can have a vaginal delivery because it's low risk of transferring HIV to the baby. The other thing you can look at on page 464 is the text box at 17-9 that talks about assisting with an amniotomy. This is actually done by the physician. It's not done by the nurse, so it's just kind of going over what to expect, what you as the nurse will be documenting. Color, odor, consistency of the amniotic fluid is always important for documentation purposes. The other thing we need to make sure that is being done is that the woman's temperature is checked every 2 hours after her membranes have ruptured. If she is displaying any type of signs and symptoms of an infection, she needs to have it more frequently. If her temperature is greater than 38 degrees Celsius or 100.4, notify the physician. Also notify the physician and make note of any chills, uterine tenderness on palpation, foul smelling, vaginal drainage, and fetal tachycardia. Some of the just comfort things, what can you do as the nurse? I mean, it's just pretty simple. If she's sweaty and clammy and she's oozing a lot of fluid, changing her bed linen, changing her gown, changing her peri pad, those types of things. Oxytocin. Oxytocin is one of those medications that is very important to the mother-baby world. It's that hormone that is produced by the posterior pituitary gland. It stimulates uterine contractions. It's used to induce labor and augment labor progression. Oxytocin is now a high alert medication. The other thing oxytocin is very important for, not only for the labor process, but it also stimulates the milk letdown reflex in the postpartum period. So for safety, oxytocin has to be visually looked at and confirmed by 2 nurses. Hazards to mom, what can happen? What are complications? Placental abruption, uterine rupture, sometimes unnecessary C-sections because of abnormal fetal heart rate because of the oxytocin medicine and patterns. Postpartum hemorrhage and infection is at higher risk for mom. Baby can experience acidemia and hypoxia. This usually will result in a late deceleration. The half-life of oxytocin is 10 to 12 minutes. It usually takes about 40 minutes to actually reach the state of where you want the oxytocin to be doing that job of stimulating the uterus contractions. In your textbook, the medication box about oxytocin is on page 466. So this is a picture of the physician using forceps on the baby in order to assist the baby's head out. There is different types of forceps and different names. You guys do not need to remember the different names and types of the forceps. What I really want you to know from forceps is what are the nursing considerations. It does look like, I think it looks like salad tongs. It does not look pleasant at all. And one of the things that the nurse can explain to the mother is probably not to tell her that it looks like salad tongs. Your book describes to tell the mother that the forceps blades actually fit the same way that you would take 2 spoons or tablespoons and put them around an egg. The blades are placed in front of the baby's ears in order to use them for assistance to pull them out. After birth or after forceps are used and baby is born, we need to assess mother for any kind of vaginal cervical lacerations, urinary retention, hematoma, and any kind of damage to the soft tissues in the pelvis. Baby needs to be assessed for any type of bruising or abrasions and any facial palsy. The other thing that we need to assess baby for is a subdural hematoma. They do not use forceps and vacuum assist very often anymore. There used to be a time where it was used in every birth. There were too many risk factors and too many complications of brain damage, and they got away from that a long time ago. So this is a picture from your textbook of them using a vacuum, and like I said, I have forceps and I have a vacuum, so I will bring those into class so you guys can see those. It's used on a negative pressure type system. You cannot use a vacuum if the baby is less than 34 weeks gestation. What are some of the prerequisites that you need to have in order to be able to use the vacuum? They're completely dilated cervix, they have a rupture of membranes, and the head is engaged. Baby's in a vertex position, remember, head down, and there is no suspicion of CPD. Because if moms have CPD, baby's not coming out vaginally. What are some of the nursing considerations if you have a patient who is having a vacuum-assisted birth? You're kind of the support person, the educator. You want to let them know what's going to be going on. You're assessing the fetal heart rate, and you're documenting the procedure. After birth, we're assessing newborn for signs of trauma, infection, and we're actually looking at the application site because there are some times that it can leave a little ring on top of their head. So you want to assess that. You want to assess that baby doesn't have any cerebral irritation, that there's nothing wrong with their suck reflex, they're not lethargic, those types of things. The other thing with a vacuum-assisted birth is it puts that baby at high risk for hyperbilirubinemia, which we'll talk about when we get to the newborn chapters. I think for the rest of the chapter, for the most part, we're going to talk about C-section or a cesarean birth. and what that means in talking or taking care of the patient who's had this. So what is a cesarean birth? This is where the baby is removed. They do a transabdominal incision in the uterus and the baby is moved out. What you're looking at on your screen are the different cuts that they can do in the uterus to actually assist the baby out. But what are some risks first of a cesarean birth? Moms have a higher risk of endometritis, blood transfusions, and clots because they do stay in the hospital longer. They usually are on bed rest for about the first 12 hours. They usually really try to encourage them to get up and move around. They're also at risk for respiratory problems. And there's also greater complications in subsequent pregnancies, including uterine rupture and placental implantation problems. So they're a higher risk for placental previa and a rupture. So scheduled cesareans, they can actually schedule a cesarean section. They will do this if you've had a previous C-section. They will also do this if they know a vaginal birth is contraindicated. Mom has genital herpes that are active. That's the key word, active genital herpes, positive for HIV with a high viral load. That's the other key. And she has a complete placenta previa. She cannot deliver if she has a complete. The other thing is if maybe there's a poor uterine environment, mom is too hypertensive, they may schedule a scheduled C-section. So they're going to know that ahead of time. The other times, an unplanned C-section can occur when maybe labor is not progressing, there's an emergency, so baby's in fetal distress. Those are some of the reasons why they would be unplanned. So what you're actually looking at on your screen are the different cuts, and with picture A, you're looking at a low transverse incision. You will also hear people call this the bikini cut. You'll hear mom say, "Did they give me a bikini cut?" That's what that is. That would be the low, little, small scar that you would see at your bikini line. The picture on the B picture is what they call a low vertical incision. And then picture C is actually a classic. This looks very small on the picture, but it's the staples on the outside. When mom has a classic incision, is just like if she had a big abdominal surgery. It's usually about 2 inches below her belly button down to the sympubis. So it's a pretty extensive scar and puts her also at higher risk for infection because they actually staple that. A and B picture, they usually can use Dermabond and actually glue it. They don't necessarily have to put staples on there. What else can occur? Complications and risk, maternal complications, aspiration, hemorrhage, atelectasis, abdominal wound, infection, UTIs, injury to the bowel and bladder, because they are essentially cutting mom open. There's some pictures in your textbook. I don't know if I put them on your PowerPoint. It kind of goes through what to expect, perioperative, intraoperative care, and that starts on page 472. You guys can read and kind of review that over. Immediate post-op care or focuses on the mom, taking care of mom. She goes to the post-anesthesia recovery room. One of the things to keep in consideration is when moms have C-sections, they don't always get their baby handed. They get their baby handed to them during the C-section, and they can kind of love on them for a few minutes. But usually the baby is taken to the nursery because mom needs to recover. There's this period of time that bonding doesn't occur, so just kind of keep that in mind. So you guys can kind of read through some of the things that happen pre-op, intra-op, and post-op. Pain relief, Splinting education's key with moms. We don't want them to just get up really quick, splint with a pillow when they move, when they cough. They can use some relaxation techniques. The other thing that occurs with these moms is they get gassy. It's like any kind of surgery. Peristalsis is slowed down because of the anesthesia. So we want to encourage them to get up and walk. No using straws. Have them lay on their left side, maybe kind of rock in a rocking chair, but we don't want them to stay in bed. We don't want to give them carbonated drinks, that kind of stuff. The other thing is usually these moms have a Foley catheter, and depending on where you go, there's going to be a protocol. There's going to be a protocol for a vaginal delivery, and there's going to be a protocol for a cesarean birth. For the most part, if they have a Foley catheter in, it's removed within the first 24 hours. They usually will have TED hose or SCDs on because they are in the bed for at least 12 hours, if not longer, just depending on the physician. The other thing is we want to educate moms on what they need to make sure that they're assessing themselves after they've been discharged. Temperature greater than 38 degrees Celsius, difficulty urinating, urgency, cloudy. They need to monitor their lochia flow. They're actually going to monitor their incision because they usually don't, if they have a classic, the staples usually aren't removed before they go home. So just some of those types of things and teaching. Now I'm going to talk to you about a term that's called trial of labor. Trial of labor, this is where we're actually trying to assess the safety of a vaginal birth for a mom and a baby. It may be initiated if mom's pelvis is adequate size and shape. The most common reason that we're going to do the trial of labor, or they'll call it TOL, is if she wishes to have a vaginal birth after a previous cesarean section. So mom had, let's say she's pregnant, second baby. First baby, she had to have a C-section because maybe she had a breech presentation. So if she had a breech presentation, she has, it did not mean necessarily that her pelvis was in inadequate shape, or, there was no serious complications, that no issues, that mom really could not have delivered vaginally, except the baby was not in a favorable position to be born vaginally, so they had to do a C-section. So they will do a trial period, usually about 4 to 6 hours, to see if mom can labor and progress. And if she is able to do that successfully, mom can have what they call a VBAC. A VBAC stands for vaginal birth after cesarean. Some of the reasons why they would say yes, you can try to VBAC is mom had a dysfunctional labor. She had a breech presentation, or maybe there was just abnormal fetal heart rates. Maybe for whatever reason there was some fluky thing and this baby had a decel, but when baby was born, everything was fine. So the other stipulation is mom has to have had a low transverse uterine incision done when she had her C-section. She cannot have that classic incision and be able to VBAC. The major complication and risk for mom if she does VBAC is that she has the potential for uterine rupture.